Right, so now on to paediatric sepsis recommendations. So I'd like to invite Brendan McMullan to the stage. So Brendan is a paediatric infectious diseases physician, microbiologist and researcher. He works at Sydney Children's Hospital, Australia, and is also a senior research fellow at the University of New South Wales. Brendan's research interests include antimicrobial use, stewardship and resistance, as well as bloodstream and fungal infections affecting children and young people. He's passionate about advocating for improved infection management and antimicrobial use in children. Thanks, Brendan.
All right, thank you very much. I think Ed has done a lot of my work for me already, because even though he very carefully explained the caveats that he was speaking to sepsis in an adult context, you'll note that quite a lot of that also applies to paediatric content, and it really was a collaborative process across multidisciplinary adult and child health practitioners and editors, as well as that paediatric subgroup review of the topic I'm going to be talking about. So let's see, have I got the right one? That's the one. So look, I'd just like to echo the acknowledgement of country that's already happened, the Ngunnawal people of the lands we're on today, as well as the Bidjigal and Gadigal people of the Eora Nation where I live and work, to pay respects to elders past and present and extend those respects to Aboriginal and Torres Strait Islander people joining us today. I don't know, how did you do it so perfectly, Ed? I'm having the same challenge. Yeah, thank you. Ed has covered a lot of the topics about the approach to sepsis in general. I'm going to focus now on the new content for paediatrics and neonates. So Antibiotic 16, the last version of this guideline, already introduced new content, substantial new content in terms of paediatrics, but neonatal content for the first time. What you can see there, though, is that the content in the previous edition only applied to a limited group of term neonates and didn't cover many hospital-acquired aspects of sepsis that we do have to deal with, those of us that treat children with sepsis and suspected sepsis. So the new content you can see here, we've got all of these kind of new areas, new content for preterm neonates, new content for hospital-acquired infection across the neonatal and paediatric age group. Now, for neonates specifically, antibiotic regimens are a little bit complex in terms of there's not one size fits all approach. We have taken an approach in this guideline after extensive discussion to continue an early onset, late onset sepsis dichotomy reflecting real-world recommendations and practice, acknowledging, however, that this is not a true divide at 72 hours and not an absolute divide. It is in fact a spectrum. But in reality, for early onset sepsis, for that sepsis in babies presenting in the first couple of days of life, recognising that causative organisms are most commonly acquired from the flora of the birthing parent, the mother, and the antibiotic recommendations reflect that, whereas with late onset sepsis, we need to consider that sepsis can be acquired the same way from the birthing parent, but also from the caregiving environment or from the home environment in community onset sepsis. And the paediatric group discussed this extensively and considered that in the Australian context, these divisions are still generally applicable. So here is a quick subdivision summary of the antibiotic regimens for children younger than 2 months. So someone in the audience mentioned that we still need gentamicin recommendations for neonatal sepsis, etc. Well, this time we are recommending empirically tobramycin as an alternative to gentamicin. So they are both recommended, reflecting that change that Ed has mentioned, where there is this transition to tobramycin use, but also reflecting the fact that some people in some settings are not in a position to make that setting, and we still think it is appropriate to recommend either gentamicin or tobramycin as your empiric aminoglycoside, for example, in early onset sepsis. In the neonatal context and the young infant context, there is a further divide in that meningitis may be something that is missed, if not suspected and looked for, so the recommendations reflect that. So the aminoglycosides are recommended for neonates that don't have meningitis, and a third generation cephalosporin is recommended generally for those that may have meningitis. So the antibiotic choice here, as you will see, is designed to treat the most common target pathogens, and so it's influenced by postnatal age, by whether the infection was acquired in the community or hospital, whether meningitis has been excluded, and there's some text around how to do that and in what situations a lumbar puncture is generally recommended for that, as well as inclusion of late onset sepsis of infants in hospital. There was a lot of debate about the wording, and it's been chosen very carefully to not tell doctors and prescribers how to do their job, while being essentially a safety approach in keeping with current best practice for pediatrics and neonates. You'll see there's some add-on vancomycin for the children at risk of MRSA, and add-on therapy with acyclovir is recommended if there's suspected herpes simplex virus encephalitis or neonatal herpes simplex disease. So here's an example of what it looks like in the guideline. Apologies, some of that text might be a little bit small for some of you in the audience, but this is just to get a sense of how it will look in the app or on the desktop version of the guideline. So what you can see here is we've got a recommendation for either gentamicin or tobramycin, and that's been consciously put first because we recognise that getting the aminoglycoside in first with a push is most practical in that neonate with early onset sepsis, and is the recommended way to do things, plus benzylpenicillin. And as you can see here, that additional text around adding acyclovir in neonates suspected to have HSV infection. So the wording around the non-meningitis sepsis is aiming to be informative and applicable in our setting. Again, apologies for the small text, but with the expansion of the scope, significant expansion of the scope to include preterm neonates, we had to make some tricky choices around how best to present the information on dosing for preterm neonates. So the first step was actually agreeing on neonatal dosing, and that was, we took into account the consensus of the multidisciplinary members of the group, as well as information in the Australasian Neonatal Medicines Formulary. So that was one thing, big achievement. The second achievement was actually agreeing on how to present it. And so we think we've got the balance right here with presenting information based on the postmenopausal and postnatal age in as clear a fashion as possible, aiming to make that dosing easy for the prescriber. And moving on to the non-neonates or the children, the infants and children who are 2 months of age or older with sepsis or septic shock. Again, we've got recommendations for those with community-acquired sepsis and hospital-acquired sepsis. I'll just take a point out to say Ed talked a bit about the definitions for sepsis and septic shock in the adult guidelines. They're quite clear and explicit. For the paediatric guidelines, we recognise that defining paediatric sepsis remains a contentious issue. People who work in child health may have seen the Phoenix criteria published by Schlappbach and colleagues, and we made a conscious decision not to explicitly use that new definition, which is very well-researched but critical care focused for this edition of the guidelines. So we're not reinventing the wheel this time, and we're not proposing a major change. Essentially, people can continue to use the definitions for sepsis and septic shock in children that they're familiar with. But in any case, we are also including this time recommendations, including meropenem for those children with risk factors for multi-drug resistant gram-negative bacterial infections as for adults, and for those with sepsis and septic shock who live in tropical regions of Australia who are at risk of melioidosis and resistant infections. So the hospital-acquired sepsis and septic shock recommendations are new for this revision, and really are intended to, in general, align as closely as possible with the adult recommendations, but with those paediatric modifications as needed. Okay, there we go. There are also 2 new topics in paediatric sepsis and related conditions in this edition. So it's been recognised previously that necrotizing enterocolitis in neonates is a topic that hasn't been previously included, but is an important topic where there is variation in practice. We couldn't completely eliminate variation in practice with this guideline recommending that there is not strong evidence for one particular regimen over another, but this topic provides clinicians with a discussion of the topic as well as 2 an alternative generally appropriate antimicrobial options which are in common use around the country, which cover the target pathogens while seeking that expert advice or consulting local protocols. So those 2 regimens are either amoxicillin or ampicillin plus an aminoglycoside plus metronidazole, or piperacillin tazobactam with additional vancomycin if coagulase negative staphylococcal infection or an infection requiring vancomycin are suspected. And one thing I should also say with this is it is stressed throughout that there are going to be for example, extremely preterm neonates who are heavily pre-infected and pre-colonised, and that people should consult experts and refer to local protocols in that situation where appropriate. So that's nothing new, and I think that remains appropriate. The other new topic is additional discussion on Group B strep infections, Streptococcus agalactiae infections causing sepsis or septic shock in neonates. So it's been recognised that this is a very important cause of neonatal sepsis, and that recommendations including duration of therapy for different conditions arising from that have been lacking. So there's now a new topic on directed therapy of bloodstream infections caused by Group B streptococcus. So that includes drug recommendations for both children and neonates, and I think will be very useful. So look, my take-home messages for this topic are that essentially we've got substantially more regimens covering the bulk of empirical therapy for neonatal and infant sepsis, as well as quite a lot of directed therapy recommendations in those other relevant topic areas. There's substantially more content for preterm neonates, which I think will be applicable across the country. We've got those revised aminoglycoside options allowing people to use the aminoglycoside that's recommended in their facility. We've got a couple of new topics which I think are really important. This has all been heavily informed by multidisciplinary and national paediatric subgroup review. I've been told by the TG editors that feedback is very welcome, and that's all I've got, so thank you.
Thanks so much, Brendan, for walking us through the updates to the paediatric sepsis content. We probably have time for 1 or 2 questions if anyone has any. I think you're off the hook, Brendan. Great.